Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Seminars brought to you by Triple N Media YouTube channel, where we have more than 200 cardiology lectures for your browsing pleasure. The feature presentation today is a cardiogenic shock. So let's say you've been called in to see a patient in the emergency room who is having crushing chest pain, having palpitations, having profuse sweating, extremely short of breath, can hardly sit straight up, and he's mentally disoriented. You come and see this patient in the emergency room. The heart rate is 120. Systolic blood pressure is less than 90 millimeters of mercury. The patient is not responding to the IV fluids already given by the emergency room physician. You've already been started on some vasopressors. You listen to the patient. He's got rales over both lung fields. Obviously, he's got pulmonary edema. You look at the electrocardiogram, there's an extensive anterolateral myocardial infarction. There's no peripheral edema, and his oxygen saturation is 86%. What is your diagnosis, and how do you proceed? The clinical scenario that I just presented to you is a classic picture of a patient with an acute extensive myocardial infarction with cardiogenic shock. Cardiogenic shock is characterized by systolic blood pressure less than 90 millimeters of mercury, no response to IV fluids or vasopressors, end organ damage with a cardiac index of less than 2.1 liter per meter square, and a pulmonary wedge pressure of greater than 15 millimeters of mercury. There were various studies that were done to evaluate at the definition of cardiogenic shock, and this sort of summarizes the results from these several studies that were initially done to assess cardiogenic shock. What causes cardiogenic shock? As I already told you, ischemic heart disease is the most common cause for cardiogenic shock. In fact, 5 to 10% of the people with myocardial infarction end up with cardiogenic shock. It is more often seen in women over the age of 65 years. And these patients, if they recover from cardiogenic shock, they have 18.6% readmissions within 10 days. In order for someone to have a cardiogenic shock, there has to be at least 40% of the damage to the myocardial region. In what scenario can you expect a 40% damage to the myocardial scenario? If you have a left main occlusion, that can explain. But in majority of the cases, it is the proximal left anterior descending artery that can knock off the interventricular septum. It can knock off the anterior wall through the diagonals. It can knock off the apex of the ventricle and can very well involve 40% of the myocardium, thus resulting in a catastrophic pump function failure, which leads to cardiogenic shock and its complications. And by the way, the mortality before the advent of coronary interventions and circulatory support, the mortality was close to 80%. However, with the advent of emergency cardiac catheterizations and circulatory support, the mortality has been reduced to 40 to 60%, and with revascularization, it has been further reduced. But it is important to understand that time is of the essence. Time is life when you're dealing with a cardiogenic shock patient. Acute myocardial infarction, 80% of them resulting from left ventricular failure. And some of the complications related to myocardial infarction can put a patient in cardiogenic shock, namely acute mitral regurgitation, ventricular septal defect, or isolated right ventricular failure, or a combination of left and right heart failures. 2% tamponade and others. So these are some of the most common causes for acute cardiogenic shock. Let's move. There are a few other conditions, but they are not very prevalent compared to the setting of an acute myocardial infarction. Okay, the heart failure can be predominantly localized to the left heart in a patient with normal history who gets an extensive anterior myocardial infarction with a majority of the left ventricle being knocked off by a occlusion of a proximal left anterior descending artery. They may present with rouse, wheezing, displaced cardiac apex, and maybe some new heart murmurs. If you have been following this patient in the clinic and you hear a new heart murmur with low blood pressure, with EKG changes suggestive of ischemia, you may want to not only think about an acute myocardial infarction, you may also want to think about complications of acute myocardial infarction, namely papillary muscle dysfunction, or maybe a tiny ventricular septal defect to start with. Sometimes these patients can have combined heart failure. If you have a patient with a chronic coronary artery disease who already has a couple of stents, whose left ventricular function has been reasonable, now comes in with an occlusion of a proximal major coronary artery branch. And he can have the features of not only left heart failure, but also some features of right heart failure, such as pulmonary hypertension, orthopnea, and delayed capillary filling. The right heart failure can also be seen in patients with acute myocardial infarction if they have a right coronary artery occlusion, which is proximal, that involves the right ventricular infarction. Right ventricular infarction is associated with the significant wall motion abnormalities of the right ventricle, hypotension, and the treatment for that condition is totally different from what we do for patients with the left ventricular failure. But nonetheless, if the patient has right ventricular infarction, they can go into cardiogenic shock. A more common scenario would be somebody who has a history of heart failure, coronary artery disease, had a couple of myocardial infarctions, now get a major insult on top of that, who already had pulmonary hypertension from the heart failure, and that's a scenario where we see a combination of right and left heart failures. All right. Typically, the clinical presentation, as I have already told you, is classic in the sense you should be able to sense from 8 feet or 10 feet, even before you walk into the room, that you are dealing with a train wreck. Yes, you're dealing with a cardiac emergency. You're dealing with life, time, and action. If you look at an EKG here, what looks like a tombstone T waves going all the way from lead 1, AVL, V1 to V6. This is classic of proximal left anterior descending branch occlusion involving the entire septum, the anterior wall, and the apex that can lead to extensive myocardial damage resulting in cardiogenic shock. These patients may have altered mental status, hypotension, we already talked about, and because of significant amount of myocardial damage and ischemia, we can see all kinds of arrhythmias, PVCs, multifocal PVCs, ventricular tachycardia, VFib, and even atrial arrhythmias like atrial fibrillation. Demise pulses, I'm sorry, that's a wrong. Diminished pulses. Anyway, dyspnea, which I already talked about, peripheral edema may not be a feature in patients with just pure left heart failure, but if they had history of heart failure before, we can see peripheral edema, jugular venous distension. If there is evidence of pulmonary hypertension, orthopnea, hypoxia, and poor peripheral circulation with cyanosis, mottling, and reduced kidney function. Okay, here's another electrocardiogram which is showing a similar picture of a QS complexes in 1, AVL, V1, V2, V3, and maybe perhaps V3, that's it. In addition to that, this patient also has a complete heart block, as you can see the P waves here. So a slow heart rate in a cardiogenic shock patient is even a worst sign. That means we need to get the AB synchrony going, we need to get the heart rate up, because it is not able to meet the metabolic demands because of the reduced stroke volume. Lab tests, you're all familiar with ordering lab tests. I don't need to overemphasize. We need to check the BNP, electrolytes, magnesium, troponins, and of course echocardiogram is going to be the key factor in determining the left ventricular size, the extent of the myocardial damage, the left ventricular ejection fraction, left atrial pressure, and also right heart pressures. All of these things are going to help us. Lactic acidosis will tell us how much hyperperfusion we have in this given situation. Procalcitonin may be useful down the line, because once these patients are intubated, they are going to be prone for infection, and if you're not sure if it's pulmonary edema or patchy pneumonia, that's when your procalcitonin may come into play. But as I said, cardiogenic shock is a train wreck. It is something that needs meticulous attention, minute by minute, if we want to salvage any degree of myocardium, and if we want to get the patient out of the hospital. As far as management, we have IV fluids, oxygen, ventilation if it's needed, and they recommend low tidal volume to minimize lung damage, because these patients are on such high oxygen levels. Vasopressors, I'm going to talk about vasopressors in a minute. Vasopressors that act on the systemic circulation and vasopressors that act on the pulmonary circulation in patients with right heart failure. Of course, hemodynamic monitoring is an important aspect. We need an arterial line, and also monitor their blood gases to look at their acid-base balance. We talked about lactic acidosis due to poor peripheral perfusion. Cardiac catheterization is the gold standard in these patients to see if we can identify a correctable lesion and fix it and support later on with some mechanical circulatory devices. And we'll talk about their pros and cons. And of course, percutaneous intervention is important, and mechanical circulatory devices. Let's take a quick look at some of these entities as a general quick review. And here's an example of a patient with almost a total occlusion of the proximal left anterior descending artery, except for the septal branch here. And of course, this is the patient whom I showed the electrocardiogram with the heart block and one ABL and V1 to V3 EKG. And when these patients come with this and they have reduced ejection fraction, obviously you're dealing with cardiogenic shock. Mortality by revascularization status. When we take patients to the cardiac catheterization lab, we are trying to find out, is there a correctable coronary lesion that we can fix? And if we can fix them and give the vascular support, what are the outcomes? Here's a study that looked at those patients in places where you don't have access to the left heart cath, and you can't transfer these really sick patients to a tertiary center. But if your only choice is to treat them medically at your institution, the mortality could be close to 88.6% with no cardiac cath or interventions. On the other hand, if your institution is equipped for handling STEMI, and you can do a cardiac catheterization, and if a no revascularization attempt is needed, which is sort of very unusual, but still they had 146 patients, the mortality is still better, because once we know the coronary anatomy, we can be a little more confident as how we address the overall cardiogenic shock. If the patient undergoes percutaneous coronary intervention, the mortality drops to 45%. And if the coronary intervention is done in less than 18 hours of the onset of cardiogenic shock, the mortality is approximately 47.2%. Whereas if these patients go for coronary artery bypass surgery, even though considering the added stress and strain of cardiac surgery, still the outcomes are exceptionally acceptable, in that in the patients who went coronary artery bypass surgery, the mortality was 27.9%. And those who had the coronary artery bypass surgery less than 18 hours following cardiogenic shock, the mortality was 39.6%. So there is a little message here, that is, if you stabilize these patients for 24 to 48 hours, get them a little more stable, then the mortality may be a little bit lesser. Here is a pressure volume loop, and it may not be relevant in a patient with cardiogenic shock, But I'm just going to spend a couple of minutes explaining this pressure volume loop, because there are going to be multiple questions, especially on cardiology boards. They are real fond of asking questions of things that you never use, perhaps in your clinical practice. Anyway, point A is the end diastolic status. That's where the mitral valve is closed. That's where the aortic valve is closed. The ventricle is in a isovolemic contraction phase. And once it goes through the isovolemic contraction phase, you reach point B when the aortic valve opens. As the aortic valve opens, there is the rapid ejection phase followed by slow left ventricular ejection phase, at which time the point C represents the closure of the aortic valve. And as the isovolemic relaxation takes place, the pressure slowly comes down, and when it reaches point D, when the left ventricular pressure drops below that of the left atrium, we have the mitral valve opening. And this is how the pressure volume loop looks in a normal condition. Keep this in mind. All these points are important, and also at least for the board exams. And here is a case of intra-aortic balloon pump. And here was our normal pressure volume loop with the intra-aortic balloon pump. When we inflate the balloon during early diastole in the aorta, what's happening is it reduces the systolic aortic pressure. It increases by displacing the blood backwards, it increases the coronary flow and it increases the stroke volume. In effect, on the cardiac work is stroke volume increases effects, and A is the baseline, and of course, and the pressure is also sort of diminished and prolonged, and as a result we get a lower end diastolic filling pressure compared to a normal case. So it reduces the systolic pressure. It is augmentation of the diastolic pressure which helps to fill the coronary arteries, and there is reduction in the left ventricular end diastolic pressure. Let's look at a case of Impella. Impella unloads the left ventricle, so it removes all the blood from the left ventricle, so it doesn't have to go till this point to fill the ventricle completely. Then the pressure doesn't really, it looks like a triangle, but in reality Impella is working independent of the cardiac cycle. It is continuously taking the oxygenated blood from the left ventricular cavity and putting it into the aorta for circulation under pressure, so that you can maintain anywhere from 2.5 to 5 liters per minute. Let's see if they make any difference in terms of outcomes. That's where the million-dollar question is. There's classification of stages of shock. I just let you tell you, stage A is where the normal blood pressure, stage 5 is pulseless electrical activity, and stage D is multiple vasopressors and mechanical cardiovascular devices. So in between you have these stages, but standing at bedside, you know what you're looking at, what you're dealing with. The question is, what do you do next? You started on vasopressors. These patients are on a ventilator. You're trying to support their oxygenation level. You're trying to maintain their blood pressure. You're trying to maintain their renal perfusion, which is an important aspect to keep in mind, because these patients can go into acute renal failure, which is going to complicate the whole scenario. And this is a study showing early revascularization, all patients and hospital patients. Those patients who get early revascularization through percutaneous coronary intervention or through bypass surgery have a much better outcome that is sustained over a period of 10 years. So the message here is, if you are dealing with a patient with cardiogenic shock, we need to get mechanically involved. We need to take the patients to the cardiac catheterization lab, find out the extent of the coronary artery disease, find out how much myocardium we can salvage, how much left ventricular function we can improve, and then support the vascular system. And we're going to talk about that in a minute. So compared to the medical treatment, early revascularization has a long-term benefit in patients with cardiogenic shock. There are a number of vasopressors that can be used in the initial stages, so starting in the emergency room, trying to maintain the blood pressure. I will make a separate video on these drugs because if you're going to be intensivist, if you're going to be heart failure specialist, or if you're going to be dealing with acute cardiac emergencies in the CCU, you need to have all these on your smartphone. The initial doses, the maximum doses, the frequency of administration, and the side effects. But let us just summarize here. Phenylephrine is a pure alpha-1 agonist. It acts on the peripheral arteriolar system, causing vasoconstriction, and it is used in various forms of shock, even including neurogenic shock. Norepinephrine and epinephrine, as you know, they act on both alpha and beta receptors. They increase the heart rate, they increase the contractility, and they also cause peripheral vasoconstriction. Of course, the dosages are very similar. I don't have the dosages here, but I'm just going to go through what we have. And dopamine is like it acts on alpha, beta, and dopaminergic receptors. It increases the heart rate, it increases the contractility, it causes vasoconstriction, and of course this is most commonly used in supporting blood pressure in most patients, but in patients with cardiogenic shock, you prefer to use maybe initially phenylephrine and either epinephrine or norepinephrine to sort of give complementary benefits in terms of maintaining the vascular volume and pressure. Vasopressin is a pure vasoconstrictor. It is a second line of agent in most forms of cardiogenic shock. Dobutamine is purely beta stimulant. It stimulates the heart muscle cells through the beta receptors, and it is used in combination with other vasoactive drugs. This levosimendan is a inotropic inodilator drug used in acute decompensated chronic heart failure, maybe not so much in patients with cardiogenic shock. Okay, let's move on to some other drugs that work on the pulmonary circuit in reducing in terms of pulmonary hypertension. The most common drugs are of course nitric oxide, milrinone, and prostaglandin, which is commonly used in patients with pulmonary hypertension, and dobutamine. The mechanical devices, mechanical circulatory support, there are three main options available, namely the intra-aortic balloon, which is inserted through the groin. Then we have the impella, which is also inserted from the groin, but it's going to need a much bigger size bore, such as 22. You may have to even do a cut down. And of course, we have the tandem heart, where a catheter is inserted into the left atrium. The blood is taken from the left atrium and then brought into the circulation outside and pumped into the femoral artery. We're going to look at the pros and cons of all these mechanical interventions and see where we stand in terms of managing patients with acute cardiogenic shock. And here are multiple studies that were done comparing intra-aortic balloon pump versus medical treatment, intra-aortic balloon pump versus impella, and intra-aortic balloon pump versus tandem heart. But surprisingly, the results are not that impressive. Many of these studies show that a 30-day outcome is not very much different whether we use intra-aortic balloon pump or impella to give a reasonable cardiac output like 2.5 liters to 5.6 liters. However, when impella is used, you have much more stable hemodynamics, minor fluctuations in the vital signs and pulmonary congestion and all this, but in 30 days, the major adverse events were no different. However, Impella was associated with a decreased major adverse events at 90 days. So it is almost a reflex response. When we have a patient with cardiogenic shock, we're in the cardiac catheterization lab, we put in a stent in the left anterior descending artery, the patient is on multiple vasopressors. What do you do next? It is just natural to put an Impella and transfer them to the ICU. But we need to be cognizant of the studies that have shown that these devices don't add a great deal, but in certain select cases, they may be appropriate and may in fact improve the outcomes and major adverse events at the end of 90 days, especially with the Impella. Let's remember the mortality with medical treatment was 80%. Now we have reduced this mortality to like 40 to 60%. So there's a big improvement in using these techniques, the devices, the cardiac intervention, procedures like PCI or cardiac surgery. All right, acute renal injury is a fairly common process during the course of a cardiogenic shock. It occurs in 30 to 28% of patients with acute cardiogenic shock. That is 1/3 of patients with cardiogenic shock may develop acute renal insufficiency. And it is similar to stage 2 kidney disease with a serum creatinine jumping 2 times above the baseline, the urine output less than 0.5 ml per kg per hour for 12 hours or longer. And when there's life-threatening changes in volumes, electrolytes, acid-base balance, I think it may be time to consider dialysis. And 20% of these patients may require continuous renal replacement therapy. Just look it up. What is renal replacement therapy? Okay, let's talk about for a few minutes about cardiac complications. Cardiac complications, we already talked about ventricular tachycardia, ventricular papillary muscle dysfunction or rupture, ventricular septal defect, heart blocks, free wall rupture, which is almost invariably fatal, pseudoaneurysm, which is sort of a subacute, and pericardial tamponade can occur in a short order, especially if you have extensive damage to the myocardium, which becomes mushy, and over a period of a couple of days, it may become thin and form a pseudoaneurysm to start with and then rupture. Non-cardiac complications, they all just go. It's part and parcel of managing patients with cardiogenic shock. Infection, bleeding, renal failure, pneumonia, sepsis. I mean, these things you just have to watch and try to avoid them, but when you see them, you have to treat them. Okay, here are some major cardiovascular complications and their mortality. The overall mortality was 60%, but when these patients have ventricular septal rupture, the mortality jumps to 87%. So it pays to listen to their chest or get an echocardiogram whenever there has been a deterioration in the patient's condition. Because if this patient just had coronary intervention with PCI and you hear a new murmur and echocardiography documents ventricular septal defect, there may be a chance to take them to the OR and fix the ventricular septal defect, because without treatment, their mortality is almost 87.3%, while the rest of them, hover around 55%. So that's something to keep in mind. Ventricular septal defect could be a major threat to improved survival in patients with cardiogenic shock. Mitral regurgitation is surprisingly not having a bigger number. Anyway, ladies and gentlemen, this is a quick overview of cardiogenic shock in less than 30 minutes. And this has been a presentation of our Triple N Media. Our YouTube channel has more than 200 cardiology lectures for your pleasure. Please do watch them, and please do subscribe to our YouTube channel. And This cardiology seminars is brought to you by Triple N Media. I am Dr. Nik Nikam, and thank you so much for your time.